Hello and welcome. My name is Madiba Chaudhry, and I am the project manager for health promotion and equity at the Council of Agencies Serving South Asians. It's a pleasure to welcome you to our 14th Annual Health Equity Summit. This year's theme is Equity in Focus, Sexual and Reproductive Health for South Asian Newcomer Women. And we're really looking forward to having a very insightful and productive conversation. I also wanted to let you know that if you're comfortable, I invite you to add your pronouns and organization names on your name tag so that we can connect with one another throughout the day. And to begin our event, it's important that we take a moment to acknowledge the land on which we gather. We are grateful for the opportunity to gather on this land and thank the generation of Indigenous people who have taken care of this land long before other nations could came. We acknowledge that the work of CASSA takes place on traditional Indigenous territories of the Huron-Wendat, Haudenosaunee, and the territory of the Mississaugas of the Credit. This territory is part of the Dish with One Spoon Treaty, an agreement between the Anishinaabe, Haudenosaunee, and allied nations to share and care for the resources around the Great Lakes. This territory is also covered by the Upper Canada Treaty. Today, Toronto, the traditional Mohawk name of this area called Toronto, meaning trees in the water, and its surrounding areas are still home to Indigenous people, and we are grateful to have the opportunity to meet, work, and play on this territory as settlers. At this time, I'd like to introduce Bharat Saini, Chair of the Board of Directors at CASSA, who will initiate today's proceedings. Bharat Saini is the inaugural Director of Equity, Diversity, and Inclusion at the University of Toronto's Faculty of Arts and Science, where he leads strategic initiatives to advance EDI across learning and working environments. With over 15 years in the post-secondary sector, he previously managed human rights, equity, and inclusion at Humber College, led its employment equity program, and taught the Faculty of Business. Bharat has also led roles at Osgood Hall Law School, Oakhead University, and York University. A dedicated mentor and community leader, he chairs CASSA's board and has served on the board of the Canadian Association for the Prevention of Discrimination and Harassment in Higher Education. He is an Ontario certified teacher with a master's in education. Please welcome Bharat.
Good morning, everyone, and thank you so much for the introduction, Madiba. And also thank you so much to everyone for taking the time to join us for our 14th Annual Health Equity Summit. I would like to take a moment to express my sincere gratitude and on behalf of the board to Madiba and the CASSA team for organizing this year's summit, and also gratitude to board members that are able to join us today as well. Thank you. My name is Bharat Saini, as Madiba mentioned, and I have the privilege to serve as the chair of the board of directors for CASSA. For those that are new to the Council of Agencies Serving South Asians, also known as CASSA, and attending one of our events for the first time, I'll provide a brief introduction of our organization. CASSA is a registered charity and operates as a social justice umbrella organization representing over 120 member agencies. CASSA's mission is to build the capacity of South Asian communities so they can fully participate in the political, economic, cultural, and social life of Canada. Rather than providing frontline services, our work focuses on advocacy, training, capacity building, and policy change, influencing systemic, strategic, and policy level improvements that enhance the well-being of South Asian communities in Ontario. Our current strategic directions include health equity, supporting immigration and settlement, promoting economic empowerment, advancing anti-racism and anti-oppression initiatives, as well as fostering gender equity and empowerment, and combating online hate crimes, and hate speech. We collaborate with our member agencies and other social justice organizations across the province to advance these priorities. Once again, I'm delighted that this is our 14th Annual Health Equity Summit. It is something that CASSA is really committed to doing on an annual basis, and the Annual Health Equity Summit has been central to our work for well over a decade now, providing a space for South Asian and racialized communities to discuss and influence systemic changes that improve health equity. Over the years, we've explored a wide range of health-related topics, including chronic disease, mental health and addiction, sexual health, social determinants of health, policymaking, and not too far, just a few years ago, still today, and that's the COVID-19 emergency care and response. This year, our conversation, we'll be focusing on equity and the focus on equity and sexual and reproductive health for South Asian newcomer women, an important conversation that's often considered taboo in many South Asian communities. Again, deepest gratitude to our colleagues for joining us today, who will be sharing critical insights and leading us through several discussions on many related topics. I look forward to an engaging day with everyone here. I'm really excited for the discussions ahead, and I'll pass it back to Madiba to go over some housekeeping before we get started, and she'll also introduce our esteemed speakers. Thank you again.
Thank you so much, Bharat. So just some housekeeping rules before we move on. Today's summit is being recorded and we will be making it available on YouTube. Please keep your microphone muted when you're not speaking. And if you're comfortable, we encourage you to turn on your camera. If you'd like to speak, please use the chat or the raise hand feature. And finally, for questions, comments, and for sharing resources, please use the chat box. I also invite you to complete our feedback survey at the end of the summit. Your input is very important to us to help improve future events. You can scan the QR code on the screen to access the survey, or a link will be available in the chat. Lastly, don't forget to share your excitement and thoughts on social media. Please remember to tag us and use the hashtag 14th Annual Health Equity Summit to join the conversation. Now, without further ado, it's a great pleasure to introduce our keynote speaker for today. Dr. Harini Iyer has a PhD in Community and Population Health Sciences from the University of Saskatchewan and a master's in Reproductive and Cancer Biology from Johns Hopkins Bloomberg School of Public Health. Her expertise lies in health equity, anti-oppressive methodology, global health, and health professions education, which she applies to engage respectfully with communities and build authentic partnerships with an emphasis on equitable outcomes. She draws on her experience as an immigrant in Canada while remaining mindful of the privileges and power dynamics in the spaces she navigates. Her work has been recognized through multiple awards, including the International Association for Medical Science Educators Student Research Grant and the Research Excellence Award in Interdisciplinary Studies. Please welcome Dr. Harini Iyer.
Thank you. And thank you everyone for having me today. It is such a pleasure, and this is my first time with CASSA, and I'm really excited to speak to all of you today. I will admit I have a little bit of imposter syndrome because the speaker lineup for today is just so impressive and amazing, but I'm really excited to hear from everyone. I hope you can see my screen okay. And yeah. So, hi everyone, I am Harini, and I'll be talking about how we can be breaking barriers and advancing sexual and reproductive health for South Asian newcomers. And Madiba, please feel free to cut me off if you think I'm going over time or just in the interest of time. And so just a little bit about me to begin with. I was born and raised in Bangalore in India. And then I did immigrate I moved to the US to do my master's, and I am an immigrant on Turtle Island. I received my PhD in community and population health from the University of Saskatchewan. So Saskatoon and Treaty 6 territory was my first home in Canada. And I currently live and work on the treaty land and territories of the Mississaugas of the First Credit, also known as Toronto. So I moved to Toronto recently. And a little bit more about me is that I believe in using anti-racist or anti-oppressive methodologies. And for research, I believe in partnering authentically with communities and supporting them and building socially accountable systems that respond to the needs of the communities we serve. I serve as the Director of Research and Education with the Canadian Advisory of Women Immigrants. So that is the organization I'm representing today. I also want to shout out my colleague Zara, who's also on the call. So thank you for coming out to listen to me talk today. And I also work with the Canadian Partnership Against Cancer to lead their annual conference on cancer research in Canada. And I also enjoy art and watching Bollywood movies on in my spare time. And so a little bit about CAWI, or the Canadian Advisory of Women Immigrants. We are a youth-led community-based organization that's dedicated to addressing barriers experienced by immigrant and refugee women in Canada and girls in Canada through advocacy efforts. And most of our projects are currently focused on creating social, mental, and sexual health support for folks identifying as women immigrants, or as well as organizations serving immigrant women, and also certainly genderqueer youth as well. But I do want to begin by acknowledging that we have a lot of these overlapping words that we use. And immigrants are certainly not a monolith, right? And neither are South Asian women by any means. And we have all these different, we do have a lot of BIPOC folks who can be international students, immigrants, newcomers, refugees, or even second generation immigrants. And they all kind of in mainstream discourse fall under, like, often get misrepresented as immigrants or are painted with the same broad strokes. And that is certainly not representative of our lived experiences by any means. And a lot of times these identities also can overlap. And we are certainly aware that there are a lot of intersectionalities to our identity as well. So there's just so much that adds to contributing to unique lived experiences that we all have. Unfortunately, we do kind of often get grouped into one immigrant category when health systems are trying to be more equitable. And that doesn't really serve us very well. So just coming back to the topic of today's conversation, the first question we do ask is, what are the barriers to sexual and reproductive health for South Asians in Canada? And unfortunately, the short answer is we don't fully know yet. We don't have a very clear idea of what it is, mostly because we have a lot of the diversity, but also there's very little studies, or there's very little evidence or inquiry that has been done in Canada or even in North America to look at what the barriers are, and what South Asian communities really need, and how we can offer culturally safe sexual and reproductive health services and education to South Asian communities. Because again, there's barely anything out there even for immigrant communities, or immigrant women, immigrant youth don't have or mainstream research, education, or even health services haven't fully begun responding to the needs of immigrant communities in Canada. And even that is just so dynamic and changing. And again, there's no one answer to this, but unfortunately, there is a lot of work that needs to be done on this front. Um, and we at CAWI began our sexual and reproductive health campaign in 2021. To precisely answer this question, we were able to receive some funding that allowed us to conduct an exploratory study to understand the experiences of immigrant women and youth in accessing sexual and reproductive health education in Canada, and to then use those findings to develop a culturally sensitive SRH educational toolkit. Because our ultimate goal was to make sure that we could create resources that could then be disseminated into the community, and that we weren't depending on school systems, we weren't depending on other mainstream health systems to meet that need, which is often what happens when we work as community agencies. We are trying to fill gaps that the mainstream systems unfortunately have. So we conducted 3 focus groups with immigrant women and girls, and these included it included participants of various immigrant backgrounds, but also from India, Bangladesh, and Nepal. And the themes constructed from the discussions informed the design of this toolkit that we created. What we found from this study was honestly not very surprising, but broadly, what we found that immigrant women, girls, and youth felt that they had barriers to accessing sexual and reproductive health education. And there were several limitations of mainstream SRH that came out, and but we also identified a facilitator, which was support from community-based agencies, because they often did lean on community-based agencies, newcomer settlement agencies, to help fill those gaps or to reach out for education. And that was a good thing. But what limitations, and this was one of the first studies to really even explore that fully. There was just one other manuscript we had as a reference when we started the study. We noticed, and our participants told us, that there is a lack of existing literature on POC settler populations in Canada. And most literature that does exist is on SRH examines comprehensive sexuality education from a Western lens. So there's not really any nuances of the lived experiences of diverse communities that have been factored into it at all. And most SRH education in Canada is prescriptive, again, from a Western lens. So it's not really there's not much power sharing with those receiving the education. So there's no real conversation on what do you need and how can we support you. It's very prescriptive on do X for Y, right? And the lack of culturally relevant content and safe spaces was very, very evident. And we heard from our participants that this pushed participants to seek SRH information online or from peers. So what happens naturally when you don't have information, like you don't have factually correct information that's evidence-based provided to you, then you rely on the internet, you talk to your friends, and that cannot always be helpful, right? And these are some of the quotes we heard. We overall heard that there was a difficulty approaching these conversations around SRH while balancing cultural values. And so one person said sexual wellness will look different for everyone. It's not just some cookie cutter that you have to fit into. As long as you go through your life, and as you go through your life, it may change, and that is okay. And that's really important for us to also remember, because that speaks to the dynamic nature of our needs. Even as an individual, what we need today is not the same thing as what we need tomorrow. And it would be helpful if someone said, if you have a cultural guide on how you talk to your parents or your family, because often you wait for your parents to bring it up, but they never bring it up. So it would be helpful to learn how to approach that conversation with your parents. Another person said healthcare providers and medical professionals providing SRH services are aware that many newcomers are coming from racialized backgrounds and from different cultural and religious experiences. So we also need that capacity building for providers there. So the recommendations we had to make broadly were to replace these cookie cutter practices with culturally responsive content and establish safe spaces for SRH discussions, to prioritize hiring educators with diverse lived experiences themselves. That way, we need to enhance representation and also create more pathways for folks with lived experiences to come into these spaces, who can then be supporting the broader immigrant community and, of course, second generation immigrants and so on as well. And also collaborate with community organizations to offer safe, culturally appropriate SRH resources. So that was a really important finding, which highlighted the need for collaboration between and within community-based agencies as well. So we really took that into consideration in our dissemination to form relationships with other community-based organizations and disseminate what we created widely. So what we did create was this curriculum toolkit, so a sexual and reproductive health curriculum and toolkit. I am happy to share that with everyone, but it's also available on our website. I should have put a QR code to that here. And we did publish an article on these findings as well. This curriculum and toolkit was very much built from what we heard from participants, and we shared that with our partner organizations that also did sexual and reproductive health education for them to use it was a tool for educators to use when they spoke to community members. Um, and what we did after that study, it didn't really stop there. So another thing we heard was that sometimes language could be a barrier. So we began translating the toolkit to French and Urdu, and we started conducting educational workshops in different languages, which my colleague Zara's on the call. She leads that piece with us for us. And at the end, we also conducted an environmental scan of sexual health curricula in Canada to look at how comprehensive it is. And we are currently in the process of doing interviews with educators who are providing education in schools to see how they feel. Do they feel equipped? Do they feel supported? What do educators need to make sure that the learners have a safe space to learn? So everyone knows that we need cultural safety, but how say like how do educators feel? Do they feel like they have a place to go to even learn that themselves? And finally, we are also creating a digitized version of this online toolkit that will be updated regularly. So we're looking into constantly updating our toolkit as well. And so this is a little bit of the workshops that we conducted. We conducted workshops we took the toolkit and translated those into different languages, into English, Urdu, Ukrainian, and French. And we've been doing workshops in different languages with with a lot of our with a lot of participants, mostly immigrant women and youth who want to participate in that. So it offers folks an opportunity to receive SRH education, not just in English. And so we have one workshop in Urdu with 3 participants, one in Ukrainian with 2 participants as well. And so we did that workshop, and we are actually waiting on looking at how these experiences were beneficial or not to the participants. So we will be having conversations with them. Just so we are also not trying to assume or prescribe anything, because we did have a few participants who said initially that they would like education in a different language, but we don't want to assume everybody wants education in like their mother tongues, right? And we conducted an evaluation of Canadian public school curricula to see how we recently published our findings. So we wanted to see if Canada has, like, how comprehensive is SRH education across the country. And we noticed that the delivery of sexual and reproductive health education varies widely across the different provinces in Canada. So from the use of, say, some provinces have really nuanced discussions on the safe use of technologies, LGBTQI plus identities, and healthy relationships. And some provinces don't even mention contraceptives, or they prescribe abstinence only methods as well. And so, what does this mean for the South Asian community? I think it means that it depends on the province people reside in as well. That clearly will also prescribe what they need and what they are receiving in terms of SRH. And again, there's no one single South Asian identity. And because we are the largest immigrant group in Canada, and we are extremely diverse, so there's no cookie cutter solution to what the community needs. But there's also a limited understanding of what the South Asian community needs. And there's in turn, a limited capacity of providers and health systems to understand the nuances of culture within the South Asian community as well. And there's also limited capacity for educators in schools and communities to respond to our needs. So this can have a lot of harmful effects that we are witnessing in terms of a lot of stereotyping and the lack of cultural safety in health systems when we're accessing services because of the biases and assumptions that kind of precede um, a, a South Asian person receiving healthcare or SRH education in systems. And so ultimately, we only know that there's no unified South Asian need or a unified South Asian, like this, we can't prescribe this is exactly what we need. Do we need chai? Maybe, I don't know, but not everyone in my family even likes chai. So even that makes me hesitate to prescribe something for all of us as a whole. So that is something that we really need to keep at the center of our conversations, that there is no one need. Our needs are constantly evolving, and so are because the contexts within which we live and breathe are constantly evolving. The background and the demographics of newcomers not only is so varied, but it also is constantly changing. And that's also reflective of immigration policies that constantly change. So folks may come in as newcomers to Canada under sometimes not safer circumstances, but sometimes there might be more stability attached to their immigration process. But sometimes folks may have come into Canada under very precarious circumstances. And again, we can't really fully tease apart people's identities or the circumstances under which they've immigrated, their socioeconomic status. There's just so much else out there. And even when we talk about newcomers, they could be newcomer immigrants, refugees, and those are completely different identities as well. So that in turn means that the supports needed will also constantly be evolving. The socio-political climate within provinces and within the country are also constantly dictating just the attitudes of people or the majority towards South Asian immigrants in Canada. And a lot of times, especially on new immigrants, that can be really jarring to be at the receiving end of something of basically racism, right? Because that's not an experience that a lot of newcomers have in their home countries, and then suddenly you immigrate to Canada and then you're for the first time you're brown, right? And then the abilities of towns and cities to respond to the needs of immigrants is also really important, because do the do the towns and cities where the immigrants are residing, do they prioritize cultural safety? How do they feel about equity? And every generation of newcomer South Asians are going to look different. So millennial South Asians had a different immigrant experience, and I'm sure the Gen Z have a different experience. But often when we are getting talked about, it's often about how the immigrant experience is, without talking about how the immigrant experience is also constantly changing, and it's never going to be constant. And what we can do, given that there is so little out there, is learn from what worked well in different contexts and adapt it to the South Asian community. And also be mindful of how the concepts of inclusion and representation can vary so heavily depending on the context within which these communications are being had. So, for instance, while CAWI, our organization, is entirely youth-led, and it's volunteer-based, and a lot of folks began this organization as youth from immigrant backgrounds. uh, Everybody has in like grown in their careers, and they are at a different stage of life than when they first started the organization. And now we do not feel comfortable prescribing what schools are going to need, or what the youth in schools right now would need, because that's a very different context or demographic that we're talking about. So we have to constantly keep asking who else needs to be a part of this conversation and who are we missing. And we really need to build more pathways for South Asian educators to be a part of these conversations. And we need inclusive and reciprocal community relationships. So even if for us to always be reflexive of the positions of power and privilege we occupy ourselves, and how we can be inviting people in from our community to be a part of these conversations, and to just reflect on our biases as well, to make sure that we are holding space in a good way for these conversations to happen. And how can we offer support as individuals is to hold space for these supportive, transparent, and constructive conversations with our peers and with youth in our communities. And fully recognizing that the youth have very different needs from from a few years ago as well. So, depending on the stage of life we are in, we should be withholding judgment essentially when we are having conversations. So we need to be making sure that the safety of the person who needs these conversations is front and center. And so how do we should be sharing amplifying the resources that do exist, and actively connect and volunteer with community-based organizations is a really good way to both stay connected with community and also understand and hear from people what they actually need and find creative ways to support them. So it doesn't have to be financially, it doesn't have to be if you don't have the capacity to show up and do something in person, then is there something you can do online? Do you any does any of the advice or the expertise that you have, is that transferable? How can you make sure that that is something that you could maybe pass on to your community? These are just some things that I think of myself as well as I navigate these spaces. And I think it's really important for us to also remember and use our culture and community identity as a strength and be very mindful that it's not a barrier. And this is what we constantly heard from our study that from participants. We always hear that there are a lot of barriers within culture as well. And there's also a lot of barriers in how the mainstream perceives us, right? Like how we are perceived among the non-South Asian community as well, or how immigrants are perceived among non-immigrants in Canada. And a huge part of that, the internal part is stigma, right? Like everybody is navigating stigma within families, system, and community systems. And so that is something that shouldn't go unignored, that shouldn't go ignored. And we should be prioritizing the needs of those who are seeking resources by withholding personal judgment and prioritizing the safety of someone who is seeking these resources. And so again, withhold assumptions of what we know about someone else's culture or religion. Don't make assumptions about what you think someone else may or may not be allowed to do within their cultures or their religion. Don't feed into any stereotypes that exist about someone's culture, but ask respectfully if appropriate and if that's relevant. So ask yourself, is this something that you want to know for your curiosity, or is that actually going to help you support them better? And if so, how do you communicate that respectfully? And we should constantly also be learning from other cultures, and we should be open to learning. And the needs of our society are also constantly evolving. So, really being mindful of that, because a lot of the studies on immigrant communities in Canada um, very much talk about immigrants as one unified group, of course, but it also talks about immigrants as it almost feels like the narrative is very static in time, and there hasn't been an evolution of how someone who was born in the 60s, the needs of that immigrant group has evolved to someone who's immigrating in 2025 to Canada. So that nuance is very much missing in a lot of the narratives, but it is important for us to be really mindful of that so that the biases we had doesn't bleed out into the conversations we have with youth around their SRH needs. So that brings me to the end of the presentation, and I'm going to pause there for any questions or comments. Thank you.
We have a question from Kristen.
Yes. Thank you so much. It's more of a comment than a question, but it just struck me. Well, thank you, first of all, for that presentation. It was so wonderful. And I'm so thankful that I could learn from you today. It just struck me, your results you mentioned at the start, it wasn't surprising, but when you walk through your analysis, what struck me was that it really boiled down to mainstream, quote unquote, not being able to support folks as well as maybe intended. And then all of the intersectionalities being built on that. So are we looking at what, again, quote unquote, mainstream is, and who is this actually working for? And again, just a thought. And again, thank you for your presentation.
Thank you so much. And I think to answer your question of who or what that mainstream is that we keep referring back to, I think mainstream has just been sort of this broader, I would say it refers to the literature out there because this was predominantly a research project. We began this as a research inquiry. So we did a lot of literature review on, so I think mainstream does refer to a few different contexts, and that keeps evolving during what we looked at as well. But it's always that we have been perceived, and a lot of the narratives around immigrants, and there are a lot of research that looks into immigrants' needs in accessing the health system. It doesn't, there is no record of it being community based, right? Or historically, it hasn't been something that comes from communities. It's more prescribed by non-immigrant communities. So that it is how the white, it is so I think it is the settler colonial systems that we have of white supremacy that are certainly perceiving immigrant populations. And I think on the same note, what we heard from participants when they used the word mainstream was that they were referring to who provided them the education, right? So if they were reflecting on their experiences during school when they were in school receiving education, then the mainstream would have referred to the school systems that they received education under.
No, that makes perfect sense. And what really stood out to me was when you did the analysis of the, I think it was this public sexual health curriculum, province by province, and how it varied so differently. I was just shocked by what some of the provinces were doing and just how widely it all varied. And I think that was really telling too. So thank you for doing that amazing work.
Thank you so much.
Any more questions for Dr. Harini? Questions or comments?
Sorry, I just wanted to say if there were no other comments, we are looking for volunteers, so we would appreciate if you could spread the word amongst your networks as well, if anyone you know is interested in participating as a volunteer. Thank you.
We really appreciate your time and perspective. I guess we will move on to the next segment of the program. To continue this conversation, I would like to introduce our moderator who will be leading the panel discussion. Maisha completed her master's in global health at McMaster University, during which she served as the health equity intern at CASSA, supporting research and consultation focused on the experiences of South Asian communities during the pandemic. So please welcome back, Maisha.
Hello, everyone. Thank you for your warm welcome. I'll be taking over from Madiba as we move into the next part of our program. We're excited to begin our panel discussion featuring three distinguished guests who will share their insights on barriers, current policies, and interventions, as well as opportunities for improvement. We'll start with brief introductions, move into a guided Q&A, and then open the floor for questions from all of you. Our first panelist is Dr. Anjali Malhotra. Dr. Malhotra graduated residency in 2005 and developed a third-year family medicine residency program in women's health, which she later completed alongside electives across Canada focused on contraception and menopause. She ran a successful women's health practice in Toronto and worked at the Bay Center for Birth Control. After moving to Vancouver, she became the medical director of options for sexual health, overseeing more than 60 clinics and improving access to contraception across urban, rural, and remote communities in British Columbia. She practiced at Crossroads Obstetrics and Gynecology, chaired the SOGC Foundation, and served on boards including the Canadian Menopause Society. Dr. Malhotra co-created UBC's Rural Women's Health Residency Program and as Medical Officer of Women's Health at the First Nations Health Authority, advanced equity, patient rights, and HPV guidelines, earning multiple national awards. Our next panelist is Dr. Rula Kitali Hawa, an Associate Professor of Family Studies and Human Development in the Faculty of Health Sciences at Western University. She's a passionate educator and researcher and draws on her lived experience as a refugee to Canada and her deep commitment to social justice. She has vast experience in community-based participatory research and has spent over a decade engaging racialized and immigrant communities in Canada, including South Asian immigrant women, in the area of HIV prevention, resilience, mental health, and stigma reduction. Dr. Hawa is the principal investigator of the YSMENA program, which focuses on sexual health and well-being of diaspora Middle Eastern and North African youth. Finally, we have Insia Mankani. She is the Policy and Advocacy Officer at Action Canada for Sexual Health and Rights, where she helps advance the sexual and reproductive health policy landscape in Canada. In this role, she works closely with parliamentarians, policymakers, and community organizations to promote sexual and reproductive health, equitable access to services, and strengthen rights for marginalized and underserved populations. Prior to joining Action Canada, Insia served at Human Rights Watch as the Senior Advocacy and Development Coordinator, supporting international human rights initiatives and advocacy campaigns. Based in Ottawa, Ontario, Insia is committed to advancing human rights, health equity, and systemic change through policy, advocacy, and collaboration. Please join me in giving them a warm welcome. Okay, so to begin our panel discussion, our first question is, from your experience in policy, healthcare, research, or community work, what are the main barriers newcomer women face in accessing sexual and reproductive health services, and how might these specifically affect South Asian newcomer women? First, we'll begin with Dr. Anjali Malhotra.
Hi, everyone. Thanks for having me. It's a real honor to be here. An amazing presentation just before this, an amazing panelist. So I'm really honored and humbled to be a part of this group. I would say like a lot of the last 20 years of my work has really been based on access to care and what does that look like. And I try to ensure that the work is going to impact everybody in some way, because although we can't say everybody needs the same services, what we can say is there are significant barriers to care within Canada that will benefit everyone when taken down. So I think the basis of a lot of the work that I've done in the last 10 years in particular has been on consent, but not consent like you go in a procedure and you sign a consent form. It goes much broader than that. So more along the lines of, is someone able to take part in care effectively? Can they actually have a fair shot at getting good care? And what does that look like? And so to do that, I want us to sort of look at, well, why aren't they or can't they? And, what is occurring to lead to subpar care or the lack of ability to take part in care. And so, break it down, and this would, of course, not be a complete entirety picture, but bias is one of the biggest ones. So when we wrote the guidelines and standards for the College of Physicians and Surgeons in BC, we had the opportunity to really put down in there real life issues. And so bias is called out as one of the main points to say if healthcare providers are carrying bias or the system itself, which I think we can all back up and say was not built in a way for people who are coming to the country or who are people of color, we can say the system itself holds within bias. And if people aren't displaying an outward approach to go against that bias and vehemently say this is not appropriate, we have barriers to care because people won't feel safe in the system, nor will they receive care that is appropriate for them. And then, of course, there are a multitude of other things. So if we looked at Canada as a whole, the geography plays into the access of care and a barrier to care. So my parents lived in northern Saskatchewan for most of their life. Now it's a whopping 35,000 people and lots of resources. But when we were growing up, we had to travel for care. And that is a very common story for employment. So when people are coming to a country and finding meaningful employment and a community, it's often not near healthcare resources. And so there's a geographical challenge in getting someone to higher level resources as needed. And that can be a cost, that can be time away from a much needed job. It can be childcare, it can be time off of work or home duties of other kids or other people living in their home, like grandparents or others. And the transportation piece. And then do they need to bring a translator or an advocate with them? Another barrier to care. So that can add another piece of it. Because although we have translation services within places, oftentimes we've heard from people, have done a lot of qualitative data collection over the last couple of decades, and we've heard a lot of folks say, that's not the English I understand. What you're telling me is not something I get. And so when we talk about the barrier of language, there's a very different barrier of language discussion to have within medicine itself and healthcare itself. Because I always say when you're going into healthcare as a non-healthcare practitioner or provider, it's a whole new country. There's new rules, regulations, signs, and languages. And so I think it's important for us to recognize that even though we can say we have translation services available, do they make sense even after that? Do the instructions and do the commentaries make sense? Does taking part in the system actually become a meaningful thing to this person? There's, of course, also the hierarchy of needs and making sure that we're aware that, people have things that are survival needs, especially when first coming to a country. Is this anywhere near the top of those needs? Where does this last? Will someone push themselves to wait to get care because it's so low down on their perceived level of needs? And so that's something to always bear in mind as well. I talk a lot about medical violence in the work that I've done. So we know that in multitudes of countries that people are coming from, including, the country my parents came from in northern India, medical violence was in fact at times government ruled. It was in fact legalized by parliamentarians. It was something that took place in droves, and millions of people have not only been a part of it and subjected to it, but their family members and friends have. And so do they even have trust within a healthcare system when coming somewhere that we've already talked about all the possible things that they're already encountering, and has there already been an experience that is unwanted? And when we talk about medical violence and sexual and reproductive health care, it's something not a lot of people want to talk to because there's a defensiveness of the system that comes into play. Whereas we can't deny that millions of women across the world have in fact been sterilized against their will. So have men. And so when we talk about sexual and reproductive health, we have to have a very honest discussion about what have people already faced coming into this, and what have their relationships and family members and friends faced as well, because it really encompasses that trust of healthcare. So I'll maybe leave it there and leave for our other panelists to have some room. That's sort of the body of work that I've worked on. And so we'll go from there.
Thank you so much for your perspective.
Thank you.
Insia or Dr. Howe, whoever wants to proceed, you're welcome to.
Sure, I can go. Hi, good morning, everyone. Thank you for having me. I mean, this is a very exciting forum and very important topic indeed. Um, I think my perspective is slightly different. I'm just going to give a bit of where I'm coming from, a bit of a background. I started my work with the South Asian community in 2013, and that was part of my doctoral research, particularly with immigrant women, South Asian women living with HIV. I had the Alliance for South Asian AIDS Prevention open their doors for me at the time when particularly the topic is very, very stigmatized, and I don't think things have changed much till today. Like that topic is still very, very stigmatized. My experience around barriers, I'm going to share particularly around two pieces of research. And when I say pieces, it means really since 2019 and onwards, so many, many studies. But I've kind of tried to compile them. I do a lot of work with the Middle Eastern and North African community. I'm an Arab woman myself. And also, I still continue to do work with the South Asian newcomer women community. Things that I found, particularly around the both communities, being newcomers, racialized. I think we need to define what do we mean by the term woman, and when we're looking at sexual health in particular, that becomes even more important. So, female identifying participants, whether they're straight, cisgender, queer gender, queer in general, sexual and gender identities, and trans women. And whenever we're talking about women, we have to think about gendered experiences as well. And, women's health outcomes, particularly in sexual health, are deeply influenced by sexist and gendered practices that they face in society. Um, when I'm thinking about barriers, I'm thinking often with newcomers, based on the research that we did and based on focus groups and interviews that we conducted with newcomer women. And I'll zoom in more on the South Asian immigrant women. Many of them face unemployment, language barriers, structural discrimination, limited social support systems, and cultural barriers that definitely increase their vulnerability towards kind of diminished sexual health outcomes. And again, as my previous speaker, Anjali, mentioned, um, these are kind of amplified and they're not really on your priority list when you're a newcomer. You're in survival, you want to find a job and maybe sexual health is not, or reproductive health is not exactly very much of a priority. Um, some of the barriers that we found from our work is family. I mean, family and mothers in particular, uh, particularly with young women, can be a big barrier because of the stigma around discussions around sexual health. Maybe perhaps these are learned attitudes through family, social norms. So there's kind of a sense of an internalized shame, many of the participants talked about the ways they were raised, they were taught to believe, and that they're not actually sexual beings. So as such, anything that has to do with sexual and reproductive health is not something that they discussed, and that was definitely a barrier. Also, a lot of the women in our studies talked about stigma, shame, and pressure to maintain sexual innocence. And as such, you have to be asexual. You cannot be practicing any kind of and involved in any sexual activity. So the pressure to be virgins, a lot of them will refer to this as kind of a purity culture, and that's very much an expectation from your own culture that becomes a barrier in terms of seeking services, particularly around sexual and reproductive health. Women also talked about barriers to health and social services and compounded layers when you are a newcomer, particularly around English language competency. The women that I'm describing in my studies, they're all Ontario based. And many are GTA. So maybe distance is not necessarily a big, a big barrier, but it can be. So they're not in rural areas. And some of the women talked about some of those barriers are real, like as in, you feel the racism, you feel that, when you go to seek some kind of sexual health services, but also some of those barriers are actually perceived. You feel that you're kind of not comfortable talking to the health worker, maybe because, there are those cultural barriers. They don't understand. Maybe there's not enough cultural competency. A lot of the women talked about that. They also feel a sense of discrimination. Women also talked about self-acceptance and development of peer support networks. They spoke of resiliency, like again, being resilient was important to them as newcomers. It was important for them to find other newcomers, like-minded women. But there was kind of layered feelings of loneliness, but at the same time, kind of combined with acceptance, but also racism seemed to be a big factor in terms of barriers and accessing services. And they also talked about the importance of community connections, finding other South Asian women who are in their network. The women who we talked to, a lot of them were part of communities in the GTA, Toronto, Peel region, and I think that helped them offset some of the barriers. Um, but definitely a big factor was having culturally responsive services. It wasn't about the translation, it was about the connections they made with those services, and they didn't think that the services were culturally responsive to their needs.
Thank you so much, Dr. Howell. And then we'll pass the mic over to Insia.
Thank you so much. I'm so happy to be here and very humbled as well because I'm not coming from a health provider perspective. I come from a bit more of a policy perspective. So when I saw this question, I was very much like, where do I even begin? But I can maybe start with our frontline service that Action Canada provides. So Action Canada runs a frontline service called the Access Line, which is a phone and text line service for people in Canada who have questions or need support around sexual and reproductive health. And through that, we hear about the many barriers people in Canada experience when trying to access care. So every year, Action Canada supports hundreds of people navigating some of the most complex barriers to healthcare in Canada, many of them newcomers, international students, refugees, or undocumented people. Last year, for example, Action Canada answered over 6,500 calls between July 2023 and June 2024. And they call because they cannot afford contraception, they cannot find a provider who will accept their insurance, or they've been denied for coverage for an abortion. And these barriers are not accidents of bureaucracy, they are the result of policy decisions that leave people without access to essential care. Those are some of the core issues. Alongside those access issues, migrants also face unique barriers that disproportionately affect women. And I've seen that within my own family. So I come from a Pakistani background. We immigrated when I was 3 years old. The way I experience care and can advocate for patient care for myself is very different than my mother, who wears a hijab, presents visually as a South Asian Muslim woman, and whose first language isn't English. Oftentimes she'll get me to come with her because she trusts me to advocate for her patient care better than she feels like she can do herself. And some of that is fear and stigma that she has grown up around, but some of that is also real and lived experience as well. I mean, with many immigrants, they have to wait 3 months before being able to access the public health system. They might be located in remote areas without access to transportation, lack of privacy to access information, and face language barriers. Many migrants also work in highly exploitative environments and lack the labor protections necessary, including paid sick days to access care without fear of reprisals of their employment and their visas being terminated. Some are sponsored by partners who are abusive and engage in reproductive coercion or control access to necessary documentation. There are also several circumstances in which accessing abortion care in Canada requires travel to the United States, like in cases of later term abortions, which are very difficult to access in Canada. And the risk of detention or deportation means that many migrants are unable to access the care they need. And all of this is in addition to the stigma that both my fellow panelists also mentioned that is faced in South Asian communities in needing to access sexual or reproductive care, or even being curious about it to begin with. I think one of the things that many people on this call will have heard at some point in our lives is, what will people say, or log kya kahenge? And it is a very big barrier in addition to the fear of the judgment that you might feel in a doctoral space as well. So I'll leave it there for the moment.
Can I just jump in? It's a panel, so I'll do that. Thank you for your work. Incredible. So one of the things I just wanted to take from the previous panelists is there have been some successes that I think that we can model from. And I'm lucky because I'm in British Columbia where we've had a lot of successes. And I think this really speaks to some of the things that we've talked to just now. So, in my role, now 20 years ago at Options for Sexual Health, that was the onset of getting free contraception into British Columbia. It took us a very long time, but it really has helped because it's dispensed in communities. So people don't need permission from another healthcare provider. You go to a pharmacy, you get your free birth control. You're not asking anyone from it. You can hide it. So that's been a really big success. And I know Action Canada, thank you, was a huge part of making that happen. Um, the other piece that's happened, particularly in BC, has been virtual care services. So because BC has more centralized services, it's been easier and faster, not easier, but faster to make this happen. So one that I co-founded was Mabel, the maternity advice line for folks. And so that's 24/7, 365 advice line. And why that's helpful is because it takes away the geography barrier and it takes away the permission barrier. So people can use any phone line. They don't need to have any type of virtual like video service or anything along that line to be able to get care a little bit more readily. They can go through a provider as well to do things like that. We have a really broad sense of virtual care in BC, so not just Mabel, but like the entire rural virtual service suite of services, which are almost all specialties, including primary care. And some of it is patient direct, which is nice. But then also in a higher level, and this kind of goes towards more governmental work, where we've been able to embed standards within BC and the College of Physician Surgeons, as I mentioned before, but also work with the Canadian Senate on changing laws and how people are treated within healthcare, specifically surrounding coerced sterilization. And so my work with the Honorable Senator Boyer now has passed through the Senate and is going into Parliament to change things. And that's the level of care and change that we need to see happen to ensure that people know that care has to be at a higher level than what's been offered now, and racism cannot be a part of care. And then the last one I'll mention is HPV screening. So there's only 2 provinces in Canada that allow people to do cervical cancer screening at home. And so BC is one of them. And so as one of the leads on one of the projects to get that here, and it was a very exciting piece of work, again, coming from a rural community myself, where the barrier of accessing cervical screening was insurmountable for many, and many when I grew up, for sure. And it has that added effect of you have to undress in someone's office to get this done. So the trauma of that, the process of that, you have to get to the office, the geography. So all of those pieces sort of vanished when we brought in cervical screening. You could order to your home, do yourself, and send back and get your results. And so it's a really big step forward. So I think we talk a lot about the barriers, and we should and we have to, but I think we should also pivot off of some of the successes that have been happening, because we have some. So, and I think it's important for us to know that we're making some room here and there and some headway here and there. And then from there, what else can we do? So it's a little bit of a motivational pivot to the next topic. So,
Thank you so much, Dr. Malhotra. That was actually very insightful. Thank you for giving all of your insight. So our second question is actually exactly what you just addressed. So maybe you can just touch on the second portion of the question, which is, where do significant gaps remain? And for our other panelists, the next question that we're proceeding to is, what current policies, programs, or interventions have been most effective and successful in supporting South Asian newcomer women?
I can go last because I just talked.
I can jump in here if we want to flip
For
the order
sure.
around.
Sure.
So a big one is, I think, as Dr. Malhotra mentioned, the access to pharmacare, which is huge. The universal access to contraception, which BC has now implemented. We've seen now Manitoba has signed an agreement, PEI. We have Yukon that signed an agreement. Implementing the pharmacare program is one of the clearest, most evidence-based investments a government can make in people's health, equality, and economic security. It gives people real control over their futures. It reduces health system costs. It strengthens gender equity across the board. Before BC implemented the free contraception program in 2023, nearly 30% of contraceptives were paid for out of pocket within a year. Within a year of implementation, pharmacists reported a 60% increase in uptake. And the cost modeling shows that the program will pay for itself within 4 years through reduced unintended pregnancies and related costs. Access to contraception coverage could have huge implications for the safety of migrant newcomers, particularly when they face reproductive coercion. But currently, the barriers to access are still prevalent and fall disproportionately on marginalized communities. So we've seen that 3 provinces and 1 territory have been able to sign on, but we do need to see more political and financial will from the current government to push those agreements forward with the rest of the country. So Action Canada has a contraceptive access map that I help run. It's Contraceptive Atlas. And on that, you can see that there are still different levels of access. So the level of care that you can access in your province depends on where you live and is very dependent on your postal code at the moment. So I think that's one of the gaps that still exists, but also a huge success in the last year as well. Another big one is access to sexual health education, because a person can't access rights they don't know they have and services they don't know are available. When we say sex ed saves lives, it's not an exaggeration. Growing up, I think a fear my parents had around sex ed was it would encourage sexual activity, but we know that's a myth. Sex ed in or out of schools does not increase sexual activity, sexual risk-taking behavior, or STI or HIV rates. It gives people the right information to take better care of their bodies. This means fewer sexually transmitted infections that can have lifelong complications, fewer unplanned pregnancies, a decline in reproductive coercion, preventing cervical cancers or catching them earlier, less health issues caused by ignoring symptoms because of shame or fear. It also helps create safe learning environments for marginalized communities. And that's not to say it doesn't need improvement. Right now in Canada, the sex ed most young people receive does not meet international standards and best practices, nor does it meet the 2019 Canadian guidelines or the CCAN guidelines for sexual health education. But when done right, sex ed addresses the root causes of negative health outcomes. And we are seeing a rollback in a lot of provinces that are trying to create opt-in sex ed, as opposed to opt-out, which creates another barrier to accessing care. And the final thing I'll mention is access to sexual health centers like the ones Options helps in BC as well, because they're so crucial. Community-based sexual and reproductive health centers are part of a strong healthcare ecosystem. They provide contraception, pregnancy support, abortion referrals, and sexual health education, often as the only point of access for newcomers and the uninsured, and they're able to provide safe spaces and culturally sensitive care, which can be a major barrier to access, as Dr. Hawa mentioned, for a number of South Asian communities. Yet most haven't seen core funding increases in over a decade and are operating beyond capacity. So holding together essential services with shrinking budgets and rising needs isn't something that's sustainable. So again, like a success because these sexual health centers really do help communities and protect lives. But again, there needs to be more financial will seen from the government to protect these.
Oh, wow. Thank you. I mean, you touched upon a lot of great things, and Sia, like particularly around the community-based work and the role of community-based sexual health clinics, which I feel like are extremely important when you're thinking newcomers and especially, I mean, again, my scene is an Ontario scene where you have a lot of wait lists and already there are barriers around language and access in general. And when you're talking sexual health and reproductive health, it's even more taboo that people, a lot of particularly the women don't want to talk about. I'm just going to bring in more the perspective of interventions, being again, not a service provider, mostly involved in research. And I'm going to share, again, from the many interventions, I'm going to focus on one that we particularly completed with the South Asian women and with the South Asian AIDS Prevention, ASAP, Alliance for South Asian AIDS Prevention in Toronto. as definitely the lead and the partner. So we had about 78 women who self-identified as South Asian, aged 18 to 60. So clearly, some of those women, well, all of them will be requiring sexual health, but not necessarily, in the reproductive years. We ran 11 focus group sessions and we did run an intervention. What's really unique about the intervention is it was peer facilitated. So we relied on peers that were trained from the communities to kind of run the intervention, but also run the focus groups. And we thought that was a very significant model as opposed to us as researchers being part of that, just to kind of remove some of those barriers around power and coming across as we are kind of the knowledge keepers or maybe the experts in the field. So what we did is we randomized the women into two groups, and one group received the kind of regular, conventional, factual information from Toronto Public Health. So these were fact sheets around HIV, HPV, chlamydia, anything around sexual health. And the second intervention was mostly about culturally relevant stories. And what we tried to do is we made those stories very kind of comparable to the Toronto Public Health fact sheets, except those stories were developed by South Asian women. They were telling stories of women in the community. So when we randomly allocated the women to either the fact-based or intervention or the story-based intervention, we then ran the intervention, and then there were focus groups after that to kind of discuss what happened, what worked, what didn't work. And what we found that storytelling in general is a very effective strategy for adult sexual health education. And the reason for that is, I mean, what's so unique about storytelling is a lot of things. It's culturally competent. We just heard about sex education in schools and to what extent, and now the opting in and the opting out. I mean, we see like a movement now, I guess, across Canada around sexual health education not being very important and not being part of the education that you take in regular school system. So what we really, the storytelling work affirmed to us that a culturally competent curriculum is very important. The stories were culturally relevant compared to the fact sheets. The women related to the stories. They thought the messaging was more important to them. They could understand the messages that they received. We measure things like information that they learned. We also looked at attitude towards access and pursuing sexual health. We looked at recommendations, like what do the women want to see, and from kind of capturing their own voices. And so this is definitely a particular area that we hope maybe more so in sexual health clinics, there would be possibilities. We try to share a lot of the information that we have around those areas with communities to make sure that there's not a huge reliance on just those pamphlets and fact sheets, and more kind of engaging with the community, engaging particularly with the women in order to kind of increase some of that awareness around their bodies, around awareness around the importance of sexual health and how they can keep themselves safe and healthy. And again, going back to the gaps, the big gaps clearly remain as cultural competence and cultural relevance. And I think uh, having that intervention, particularly around story sharing and storytelling, embedded a lot of that cultural relevance. The women saw images that they could relate to. They listened to stories for women that looked like them, spoke the same language, so to speak. And we feel this could be a particular strategy. And I know we're talking about strategies at a later time as well. But yeah, thank you. I think we've got some really amazing perspectives, like different perspectives for sure from the panelists.
I'm just going to jump in from the clinician's point of view on this. I think having worked in this field for so long, it's really important for us to know that more funding is very much required for clinical services in this area. And I know we say that a lot, but it's a very low paid specialty within healthcare. And so even healthcare providers who are doing the work are at times, it's almost volunteerism. And so I think it's important for us to know that it's a passion of very many people, but a lot of funding needs to go into supporting places like OPT to ensure that. So in British Columbia, we have 60 clinics-ish. Now I think it's 50 throughout the province that service multiple rural and remote communities and urban centers. That's direct patient care and often serves as someone's family doctor at times because often there is no other service available, and that might be the only service they need, that's sexual and reproductive health care. And people come back for decades and keep coming for their services. But the funding model is not one that is firmly planted as a secure model of care. And I think I can say that as far as most of the sexual health clinics throughout the country have the same issues faced as far as just sustainability of the model. And then the other piece, just to dovetail into Shirley's comments about education, on all levels of education in all healthcare specialties, nursing, pharmacy, family medicine, medicine, surgeries, all of it. Um, what we lack is, in fact, education specifically about cultural safety. It's trying to be embedded into many services, and that's a fantastic move forward. But it's almost a specialty in itself. Do you understand the people you're serving? Do you know about them? Do you know their stories? Have you heard their stories? And what does that look like? And so you'll see a lot of the work that's been done of recent has been that. So things like, the First Nations Women's Health Report and things along that line, the answering the call and things like that, but not for every group. And certainly not embedded in curriculums. And I think that that's a really big step that needs to happen, that whenever we're creating, a new educational facility, one of the things that we need to ensure is that the curriculum is strong enough to serve the people that that facility will be serving. And we can certainly go back in time and embed it into curriculums that exist now. But it's a necessary step, in my opinion. Like, I think if we don't know the people we're serving and we don't know their stories, we're gonna have a very hard time having a community of practice that serves really effectively. So I'll leave it there.
Thank you so much, Dr. Malhotra, Dr. Ha, and Intia for discussing the successes in healthcare practice, policy, and research. It's evident that these barriers that have been discussed overlap between your disciplines, and through the partnerships, many successful and sustainable changes have been implemented to improve health outcomes, access, as well as quality of care and resources available to South Asian women. While there have been partnerships, I wanted to ask, have there been any disconnects between healthcare policy and research regarding sexual and reproductive health that can be bridged moving in the future?
I'm happy to go first on this one. I think there are definitely disconnects that we see in policy making, and I think one of the strategies we definitely need is cultural sensitivity, not just in providing care, but in policy making as well. So we need an increased understanding from policymakers about how implementation might affect immigrants, particularly women, especially as we see multiple cabinet bills coming through the House of Commons at the moment. And you can see many of them are well-meaning, but they lack the nuance needed to make real change, and they don't account for how those policies are going to be the effect they're going to have in community. So an example of this is in Budget 2025 that was introduced recently. There's an introduction of a new co-payment model for the Interim Federal Health Program, or IFHP, requiring refugees and asylum seekers to pay a portion of the cost for health products and services such as prescription medication and dental care upfront. And while framed as a modest adjustment, even a small out-of-pocket cost can deter people in precarious circumstances from seeking care. And this is especially concerning for sexual and reproductive health. And we've already heard experiences from newcomers without insurance that we've helped on our access line, that are being required to pay for every service as it's delivered. Payments for medications, surgeries, consultations, lab tests, the list goes on. And providers have already reported difficulties with IFHP to begin with. So the administrative burden of reimbursement often means clinics turn away patients and that leaves people without a lot of options. So adding co-payments introduces another layer of complexity, requiring clinics to collect fees upfront and manage new billing processes. And the result will be fewer willing providers, more barriers for patients, and ultimately higher public costs as preventable conditions become emergencies. And what begins as an attempt to save money ends up costing more in both dollars and dignity. Another example is Bill C2, which was introduced as a response to organized crime and border threats, but proposes sweeping changes to Canada's immigration and refugee system. And this has also been amended where a lot of the same policies are reflected in Bill C12. But the legislation fails to acknowledge the realities of survivors of gender-based violence, many of whom arrive in Canada with profound trauma, fleeing life-threatening circumstances, and the bill represents a direct attack on the rights of refugee claimants and migrants by imposing rigid timelines, expanding discretionary powers of the Attorney General and the Minister of Immigration, and enabling the sharing of personal information without consent and conflating irregular migration with criminality, all of which disproportionately harms the most vulnerable. Survivors fleeing gender-based violence abroad are learning about legal processes with the added burden of living with trauma. And many are forced to do so under the control of an abusive partner who may restrict their access to information, support networks, or community resources. Others may be exploited due to their vulnerable status, experience forms of harm such as sexual violence, forced marriage, economic coercion, labor exploitation, and other intersecting abuses. And imposing strict time limits on the most marginalized refugees ignores Canada's commitment to gender equity and safety. And at a time when all of these bills are moving through at such a fast pace, we cannot afford to be blind to these things, and we cannot afford for policymakers to be blind to these things, especially during times of global attacks on human rights and specifically on sexual and reproductive health care. Our policymaking and our advocacy for sexual health and rights must be intersectional and universal.
Amazing. I have just one thing to add. I think, well, by being well-meaning in a lot of the work that's being done in policy, and I think this really just echoes what's been said, is at times the folks that are going to be utilizing the service and taking part in the service are not a part of the development of the policy. And I think that's been an ongoing issue within the Western world in general. And I don't think that's specific to this time period, but it's an important thing that we need to challenge and we need to move forward in saying, the stories that have been collected and continue to be collected are the ones that need to be modeled to make policy out of. So I think that's the most important change I would see as being needed and it's an ongoing barrier in the creation of policy.
Excellent. Again, I think my contribution is different, which is actually good because I think we provide a more kind of wholesome contribution to the topic. Again, my work is very much driven by community-based work and community-based research. So when I'm thinking cross-sector collaboration, I'm thinking how can we have services that are culturally responsive. I'm often thinking of what do the women really want? So what are the voices of the women? And again, we heard that not often women are involved in the policy making, which is again, I think it's a huge issue in general in terms of kind of integrating the lived experiences of participants. So from our work that we did with South Asian new women who are newcomers in Ontario, particularly in the Greater Toronto area, advocacy was a big one, and definitely sexual health education at the community level. Not necessarily those were women, not necessarily were part of schooling. They were not necessarily in the school system somewhere, at any university, etc. But I think outside that, the role of community-based organizations and more health clinics and what role do they play. So some of the recommendations that the woman provided uh, based on the focus groups that we ran and the stories that we listened to is story packages. The woman wanted a lot of the sexual health material to be kind of presented as a tool and part of sexual health education. And in order for that to be culturally relevant, the woman could relate to that. So these would be more like stories in the form of sexual health packages. We proposed that to Toronto Public Health with the hope that some of that will transform, and we could see some of the pamphlets now having more of the scenarios, but not necessarily sexual health packages. I could see the role more of community-based organizations doing more of that work, and particularly sexual health clinics in the community. So with those packages, what the woman recommended is stories would be a short list of the facts related to health conditions. So, where do you want to go for certain procedures, a lot of knowledge base, but also scenarios, how to handle particular situations. And the package would include a visual accompaniment and perhaps a list of health-related contact information. And these would be more, clinics, services, physicians, family doctors, etc., that would be more culturally responsive to the needs of the woman. Also, the woman talked about language and translation, and they said that even though when they go to doctor's visits, etc., translation is like, interpreters are available, but they wanted material to have simple, clear language and definitely translated in South Asian languages. Women also talked about videos and animation. They said maybe something about animating stories and sexual health information. Maybe that would make them a little bit more accessible. Maybe it will break some of the barriers around stigma and would increase some of those strategies and discussions around that. And again, very important with those, these are culturally appropriate videos as educational tools with potential of nonverbal video messaging as well. These were all recommendations. Women also talked about addressing gender and cultural norms and because sexual health is not in general openly discussed or perceived by community members as a need, there needs to be some kind of platforms for opening those discussions. Participants again talked about sexual health education models and saying that there's a huge gap in the sexual health education that they receive. And while stigma and gender norms around China's being shy to talk about the topic prevented the easy discussion, but a lot of the women mentioned the role of the family, and they said that this is a place where it needs to be a site of sexual health conversations. And I thought that was very interesting because we saw very similar messaging in the Middle Eastern community with the women that we talked to. They also mentioned the family as being a very important site of sexual health conversations, and particularly multi-generational. So a lot of the women talked about, maybe grandmothers and mothers, and that could play a very important role to break some of that stigma and also to kind of create that comfort level with in terms of seeking resources. And in terms of interventions and having those kind of collaborations between sectors, having peers, so training peers can actually bridge some of that disconnection or divide between perhaps particularly the young women and maybe mothers who are newcomers, first generation Canadian. I feel like having the peers run some of those interventions can bridge some of that. And I think some of my other panelists talked about training for healthcare providers, particularly having culturally competent and culturally relevant training. It's not in the medical school training, but maybe perhaps we need to have some of that infused in some of the curriculum.
And even in some of the ongoing education, so some of the things like we brought in equity rounds, and so we could take stories like you've collected and raise them up to a provincial level. But having it be deliberate, I think, is the piece that's really necessary. And I think we're all saying that in everything we've explained today.
Thank you so much. While we have touched on our final discussion question through our discussion, what are the key strategies or changes, whether in policy, programming, or cross-sector collaboration, that could improve access, cultural responsiveness, and the overall effectiveness of sexual and reproductive health services for South Asian newcomer women? If there's any final insights you would like to provide.
I would just reiterate creating platforms for stories to be heard and really having a deliberate approach to education of healthcare systems and all people within the healthcare system. So administration to clinical services to everyone, having that same integrated opportunity to really take part in their community in a really engaging way and understand the people that are being served in a really meaningful way. That would be my final comment.
I think I would add that we need data. We need the government to conduct national monitoring of sexual health indicators through broad-based surveys. We need that information to then be very available in like through Stats Can, but also we need information that we can share that is from an unbiased source like the federal government. We saw this during COVID, where those are the systems that work best when it's not coming from an organization like Action Canada that may be viewed as as taboo, for example. Not everyone wants to go on a site that is run by the Planned Parenthood of Canada. Going on a federal government site is often more reliable. It feels safer. It feels less judgment. It feels more judgment free. So we need the federal government to take hold of providing accurate information, particularly given the rising levels of misinformation that we're seeing. And I think the last thing I'll say is that as we've heard from the panelists as well, financial support in supporting access for immigrants and migrant women in particular, but also community support. As Harani mentioned, if you can't donate financially, donate time and effort if it's open to you. It's equally important to support policies and programs grounded in human rights that uphold the Canada Health Act and the principle of universality, requiring all people to have access across the country. And a lot of these organizations, like Action Canada, for example, we have advocacy toolkits. We have pocket toolkits of how you can provide support for people. We have media training toolkits of how you can then speak with your representative, speak with the media on issues and provide more, like make sure that your voice is heard, particularly in policies that affect your own community.
Yeah, I'm just going to add one liner around data. I mean, this is a very important point, Ncia, that you've just brought up around data. Yeah, you're right. Like we don't have a lot of data, and then I mean, again, from my work in the area of HIV prevention, sexually transmitted and bloodborne infections, I know minority groups, particularly South Asian communities and Middle Eastern communities, they're usually lumped in one pot and sometimes put as other. And one of the grants that we literally just applied for and we'll hear soon about the results. We recommended, in addition to the community-based research and all of the educational efforts that we're doing and training peers, etc., we recommended biomarkers. We said like there is a need for running in one of the sites biomarkers to find out actually what are the rates, because being lumped in other category, the messaging is, well, first of all, you're not important. And then the other messaging is nobody's tracking, and nobody's tracking things like sexually transmitted and bloodborne infections, particularly for racialized communities. So I feel like you hit a really important chord around data, and I hope we get the funding because we're running a part of the study. Biomarkers clearly is not my area, but we do have somebody in Montreal who's going to be running two of them actually, who will be running a sub component of the study that involves biomarkers. And we're hoping that that will entice the government to kind of put more funding into actually testing and more of that data tracking. So thank you for bringing this up.
Okay, thank you so much to all our panelists for your wonderful answers and for giving so many insights from your multidisciplines. So we would now like to open it up for a quick audience Q&A. Attendees, please feel free to raise your hand to speak by clicking on the reactions button or type your question in the chat, which I can relay.
Yeah, I can see a comment. I think the person left, Dr. Kumar Rath. Yeah, she's saying, I'm a gynecologist working in India. It was quite informative on the issue in Canada pertaining to South Asian women. So I feel again, when you're bringing in foreign trained physicians, they bring a lot of value, and particularly to a country that's built on immigrants. So yeah, that's a great comment.
We have a question from the CCMW.
Yes, hi. My name is Firdaus Ali. Sorry, I was not able to change my name, but I was really happy to, listen to this panel, especially to Hawa, who, I've worked with Alliance for South Asian AIDS Prevention and co-authored a study on HIV stigma in rural India. I believe it was between 2007 and 2009. So yes, a lot of efforts still needed to kind of remove the stigma. But I'd also like to point us in two directions. One is that, from the victim to the survivor mode. I think that that is so important when we also talk about patient care and sharing our stories. Because I think that, when you are in that survivor mode, it's where the activism begins, the self advocacy, which is so important. And secondly, I'd also like to mention that, I used to be with the Heart and Stroke Foundation, and we did cardiovascular clinics in faith-based institutions or places like mosques and temples, gurdwaras, and such a success, So I just wanted to say that our, faith-based organizations or institutions can really become health hubs if we let them. Sexual health is, of course, more stigmatized, but I think that if you find a champion within those settings, the win is easy, and really people come there to pray, to have all kinds of information, social gatherings, and this is where they are more receptive, to getting information around health, especially women, aging women. Reproductive health is not just for younger women, for women who are going through menopause, post-menopause. There's so much silence around it. Even in my own family, it's so difficult to talk about it. The temperaments that women experience, the physical and mental trauma around menopause. So let's start those discussions also for aging women. When we talk about reproductive health, what is happening to our bodies and minds as we age, and let's use these centers that are there available to us, to make these discussions happen. Thank you.
Can I just say thank you for those? Oh my goodness, that brings memories when I knocked at the door for ASAP, and there was for those I was looking for. I was doing my doctorate. Oh my goodness, for those. So we should connect on this, and particularly around the faith-based organizations. I think there is very important work that needs to be done. And if you have those faith-based organizations that are willing to kind of embrace this area, I'm on board. So I'll definitely connect. Thank you.
Absolutely. Thank you.
And it's interesting because sometimes we steer away from faith-based centers, but something that I think all reproductive health people that are within the field know, this is health. Like this is not just, contraception and abortion. This is healthcare. And at times it's preventative healthcare of, really, really heavy periods and really, really significant pain, as well as potential prevention of disease at times. And so I think the reframe is needed at times, and that's okay to do because it's true. It's true information, but something that I think really great point. Thank you for bringing forward that we don't necessarily always rely as heavily as we should.
And just to add, I think it really does help with the cultural sensitivity piece. I think I completely understand with a lot of newcomers and South Asian migrants. I have seen it with my own family that there is a fear that you're coming to a new country. Will your kids be able to hold on to their culture? Will you be able to raise them in the way that you were raised? Are you going to be able to give them the same opportunities? And suddenly being thrown into a new educational environment can be very daunting. But if like sex ed is being provided by your local mosque, for example, that does help alleviate some of the concerns and the fears. So I think there is an element there that can definitely be incorporated.
I see a question in the chat from Alexandra, likely for Dr. Malhotra, regarding the cervical screening. So what has the uptake been like for at-home cervical screening?
Oh, thanks for asking. So interestingly, PAP screening has been great. It's been around for a long time, and it's really led us to a point where we have been able to reduce cervical cancer in British Columbia or Canada. And that's great. But with the barriers of having to go physically to a location and undress and all of these pieces that could either develop or reignite trauma, we knew that this was probably a really good way forward. The other thing is the researchers themselves in the lab settings were very aware that this is a very specific and very sensitive test that would provide us excellent results. And interestingly, knowing all of that, in the pilots that were brought forward to introduce it, the uptake was between 90 and 100% in all of them, whereas cervical screening as PAP screening can range between 70 and maybe 80% at times, but usually around 70 that it hovers at for those reasons, that geography, trauma, and at times a lack of understanding of testing. And I think what's been great too with the advent and the introduction of HPV self-screening within BC is there's been a lot of education about HPV in general. And so about the reason you get the test, what the test is, and what that looks like. And it's been an opportunity to have funding go towards really on the ground teaching, training, and understanding of what is going on in these tests. Because although PAP screening's been on for a very long time, a lot of folks don't know why they're getting it. And they might say, well, I have to go there and undress. I'm not going to do that because I don't really know why I'm doing it anyway. Whereas now we've had the opportunity to really ignite the conversation surrounding this. And there's still a lot of work that has to happen, but it's been a steady increase in the uptake in the provincial program. And it's been a really exciting change to see. I can say even in my own practice, it's been tremendous. But in the trials that I was involved in, we literally had 99% uptake. So.
Are there any more questions? Feel free to raise your hand if you want to speak or like message in the chat. I guess while we're waiting, I'll go ahead and ask a question myself. So I wanted to ask if there's been any specific experience through your careers or your healthcare practice interacting with the community members that has shifted your like personal approach in addressing sexual and reproductive health, in ensuring that interventions are culturally responsive, but also community informed and led.
I can go. I have a kind of unique answer. So I'm going to give a shout out to my mom. So my mom immigrated in 77 when I was born, and 76 really when my brother was born, but whatever. And she was a trained gynecologist coming to Canada. And so her and my dad found work in northern Saskatchewan. And I was a part of her career and the growth of her life and her take on reproductive health. And her take was always just listen and just make sure that you sit and you look someone in the eyes and you listen to their story. And so that's been a really grounding force in all of the work that I've done. And it's been unwavering. And now she's in her 80s and has only recently stopped working. And I would say that carried on for her entire career. And I was just really blessed and really lucky to have been able to work in her office and grow with her and see her practice exist and grow and just watch it and see that this is, in my opinion, the way to take on a practice. And so I don't know that it's changed over time for me, but I would say that's been a grounding piece that hasn't changed for me. But I don't know if that directly answers the question, but it gives me the opportunity to say how much I love my mom. So and how impressed I was with her approach. So
For sure. Thank you so much. Dr. Hallorantia, if you have an experience or something similar to Dr. Malhotra that you might want to share with the audience.
Mine's a bit of a different one. When I was quite young, I had a very different gynecologist, and who I would go to with concerns and was very, like very quick, very brisk, and was like, "This is what you have to do." Like once I went in, and she was like, "Great, this is what I see. We're going to do a procedure." And I was like, "I came in for a checkup. Like, what is happening?" And it was a bit scary for me. I was quite young. She would be very open with asking about my sexual health in front of my mother, for example. And I would be like, oh, I'm uncomfortable with this. Um, she retired, and then I switched to a young South Asian gynecologist who, to this day, even though I'm like, my mother, I'm very open with my mother and I'm lucky in that way. But I know this isn't the same for a lot of South Asian communities, but to this day will like yank me into a room like, do you need a pregnancy test? And I'm like, no, I'm okay. But that level of care made such a huge difference in my experience where she was a lot more open to conversation. She wanted to take her time. She wanted to understand my experience. We would, she would ask about, does your mother know? Is there someone you can talk to at home about these things? Do you know about like your options for contraceptive care? Whereas my previous gynecologist had been like, great, why aren't you using birth control? And I was like, I don't know what to tell you right now. Um, so that level of cultural sensitivity care really helped play into my work. And I was very early on in my career when I had those experiences where it was kind of like just take the time to slow down, kind of just listen, make sure things are being done in private right off the bat. Even like you can't just assume, like, yes, I'm taking my mother with me to appointments because I need someone to drive me home. But that doesn't mean that I want everything shared with my parent, for example. So I think those were some that was definitely an experience that informed my work. But I think especially one of the things that it really factored in for me was that someone from the same community would have such a better understanding. But I also don't think that that's mandatory. I think, my previous gynecologist, if they had slowed down, would have been able to meet me at the same level as well. So I think, yeah, that was one of my experiences.
Well, thank you so much, and yeah, I mean, my experience is a mixed bag because, again, you want somebody from the community, but sometimes you mentioned it's always good to have somebody from the community. But the community can be also a very close system that can be a little bit a scary place, particularly for young women. So I do have a daughter. I mean, she's now a young adult, young lady. And again, when we went to the family doctor, the first thing that he said, okay, you need to go out and outside and I'll talk to your daughter. So it didn't sit very well with me. I changed the family doctor right away after that because I don't know why. And my daughter was young at the time. Like, so I figured, yeah, no, you're not a fit, this is not fitting. That's not working for me. But I mean, I totally get it. Like, I don't need to be in all those conversations. And clearly, I was not part of all those conversations. But then on the other hand, if you get somebody from the community, there is definitely that cultural relevance, I guess, and responsiveness, which you get not necessarily from somebody outside the community. But at the same time, that can be a little bit based on some of the stories and the narratives that we heard from many of the racialized women. It's kind of a mix. It depends in if those physicians from the community are trained properly to be kind of more open to those conversations, particularly around sexual health and women, versus or versus they're not, like as opposed to they're not. So I think maybe having more of those, and not necessarily, as you mentioned, and Sia, not necessarily they need to be from the community, but maybe be kind of open to learning about the community and be welcoming for the community and the cultures and the traditions. So yeah, no, thank you for bringing this up. Thank you.
I don't see any more questions, so we can go ahead and conclude our panel discussion for today. I'll just take a
Lisa,
moment.
sorry. Can I just add one thing? Sorry, it's
Yeah,
really
for sure, for
important.
sure.
To what Insia said, and she rightly pointed out that, physicians sometimes, whether they are South Asian or not, have assumptions. So you go with your parent or your mom or your sibling, the assumptions is that you're really close, you're not having sexual relationships. But I think that this extends beyond physicians. It's also parents. So, I'm a parent, I'm a grandparent. And I think that, women my age are sometimes in denial just because our kids are forced to lead dual lives. So we see kids leading one set of cultures or morals within the home and one outside. And then every woman I talk to, I'm like, do you speak to your kids? And it's like, no, my daughter's really wonderful. She doesn't believe in having, relationships, especially sexual before marriage and stuff. So I think that education and that, unlearning of those assumptions needs to be extend to parents as well, right? Like especially when they cross countries, they become very rigid about their religion, about their culture, the ownership of it. They kind of see that they have to do it themselves. Otherwise, our kids will become Canadian. They will become whatever their values are. And I think that that belief that their kids are not venturing out into relationships or exploring really makes the children more vulnerable, because then there is no way for them to also get information to talk these things out without people judging them. So I would love to, if people reach out to me, really to say that when we do this education, it's not just for the youth. They know enough, and they are ready to teach us. I feel, and so let's do it for the older age group to say, this is what's happening. This is the real world. The social media is so active. People are finding relationships online. They're isolated. And as parents and as elders, what can we do, to keep things safe?
Thank you so much for those. I just want to take a moment to thank our speakers today, Dr. Malhotra, Dr. Hawa, and Insia. Thank you so much for sharing your knowledge and experiences and creating such a meaningful and stimulating discussion. We will now break for lunch until 12:30. Please remain in the meeting during the break so that we can smoothly sort everyone into their breakout sessions. You're welcome to turn off your camera and stay on mute. Enjoy your meal, and we'll see you after the break.
Thank you, everyone. Have a great afternoon. Thank you.
Thank you.
Hello, everyone. I hope you enjoyed your lunch and are feeling refreshed. We're now going to be moving into the breakout sessions, where you will have a chance to dive deeper into the topics you selected when registering for the summit. While we get everyone sorted into their breakout rooms, we'll take a moment to introduce our amazing speakers. So for the Healthy Beginnings Maternal and Perinatal Healthcare Access, we have Dr. Farah Shroff. Dr. Farah Shroff is a South Asian Canadian public intellectual, a global leader in advancing health equity and education. She's the founder for Health Together, where she champions the vision for health for all on a healthy planet with a focus on maternal mortality, women's health, and the environment. A trusted policy expert, she has collaborated with governments in Canada and abroad and has served on the board of governors of the Vancouver Coastal Health Authority. Recognized by the Harvard T.H. Chan School of Public Health with the prestigious Takmi Fellowship in 2001 to 2022. She continues to collaborate with colleagues at Harvard. Dr. Shroff also celebrates her South Asian heritage by teaching yoga, dance, meditation, and other cultural practices that foster holistic well-being. We also have, for the reproductive health matters, menstrual and gynecological health access, Dr. Ann Hussain. Dr. Hussain is a naturopathic doctor, Menopause Society certified practitioner, and author of the Period Literacy Handbook. Her mission is to empower others and help them begin their personal journey navigating PCOS and the lack of reproductive health education in Karachi, Pakistan. She supports patients through all phases of menstrual life and addresses conditions such as PCOS, PMS, endometriosis, fertility, hormone health, and perimenopause with a compassionate, collaborative approach. In addition to hosting the podcast Face to Face, the Hormone Health Show, she partners with Canadian period equity organizations, translating over a decade of clinical expertise in tangible social change. Dr. Hussein believes that developing agency over health is not only a personal act, but also a powerful political tool for demanding better care and shaping a healthier world. And finally, for our Knowledge is Power sexual health education and STI HIV services, we have two speakers for the session. We have Srutika Sabu, a Malayali Canadian doctor turned artist and project manager. With a background in primary care and community-based health research activism, she has led several projects promoting South Asian health, focusing on femme, queer, and trans communities across the United States and the Greater Toronto Area. Currently, Struth serves as the idea manager at ASAP, where she oversees the Wage Canada-funded Trans Power project. This project empowers racialized, trans, non-binary, and gender non-conforming individuals by providing sexual health workshops, capacity building, mentorship, and support services. Through her multifaceted approach, she integrates medical expertise, community engagement, and storytelling to foster inclusive health outcomes for marginalized populations. We also have Alicia Ali, a neurodivergent non-binary artist and community organizer of Indo-Caribbean, Trini, and Singaporean Tamil descent. Through their work at ASAP, they have been instrumental in sexual health, sexually transmitted and bloodborne infections education, and harm reduction initiatives, particularly serving trans, queer, and South Asian and Indo-Caribbean femme communities. Alicia currently serves as the project coordinator for the wage-funded Trans Power project, which empowers racialized, trans, non-binary, and gender non-conforming individuals through sexual health workshops, capacity building, mentorship, and support services. We will now be opening the breakout sessions. So if you have not been assigned to a room or experiencing any difficulties accessing the breakout rooms, please do drop a message. And I'm sorry if I had to cut the conversation short. But welcome back to the main room. I hope you had a productive conversation. I did pop into some of the sessions and I did see there was a lot of engagement. So we will be starting the next part of our session, which is the debriefing session. So we'll hear key takeaways from each session, and I'll call out the facilitators' name, and each of them can briefly share the main points, insights, or solutions from their breakout session. So first off, I'll have Samaha from the Healthy Beginnings Maternal and Perinatal Care Access to summarize her points.
Hello, everyone. So we had an amazing session. We actually talked about a lot, so I will do my best in trying to make sure that I can highlight all the information. But in our session, we discussed how immigrant and racialized mothers in Canada do face higher risks of prenatal birth, gestational diabetes, and prenatal depression due to like cultural stigma, language barriers, income disparities, and systemic racism. Dr. Farah emphasized that prenatal well-being improves most when mind, body, environment, and community are supported together. So we looked at stuff like how yoga really helps, time in nature makes a huge difference. Dancing, we talked about how dancing, and she mentioned her own experience, how when she was about to give birth, how her and her father danced. So that was a really cute moment that she shared with us. And how culturally rooted family traditions that are built on resistance and connection are really important. We also discussed how digital tools can extend support, and because this can also help with like language barriers to receive information, and to guide South Asian women on what to do. And then like I said, it can reflect cultural and emotional needs. And then for South Asian Canadian women, blending traditional wisdom with modern health promotions offers the most inclusive and effective care. Also, social justice approaches are essential to address the root cause of inequality that a lot of South Asian women experience. Thank you.
Thank you, Sama. And next, we have Yamana from the Reproductive Health Matters, Menstrual and Gynecological Health Access.
Yes, hi everyone. Just like somehow we had a very engaging breakout session. Dr. Anne was just amazing, honestly, and it was very interesting, all the content that she shared, and very, very important as well. She presented on menstrual health through an equity lens, highlighting the barriers that are faced by newcomers, especially South Asian communities, including systemic barriers such as lack of access to family doctors, or how long it takes to get referrals, costs, navigation challenges, and so on. She also discussed clinical issues such as the normalization of symptoms, biases, short appointments, as well as cultural issues, stigma, low menstrual literacy, and so on. She said she had a very important point to comment, which is, and I really liked it, which is when she said that when you don't know what normal is, you don't know what abnormal is. And understanding that normal is a range and that we need to be educated on it is very, very important. She explained how conditions like PCOS and endometriosis, for example, are often misunderstood, underdiagnosed, or even dismissed due to all the layered barriers that South Asian newcomer women here experience. And she also stressed the need for culturally appropriate education, community-driven resources that would also utilizing researchers, healthcare practitioners, grassroots organizations, and so on, but also collaborating with the community and people who have lived experiences and who have experienced these issues as well, to understand exactly what they need and how we can access them and how we can provide them with the information. She highlighted pilot programs and how it's really important to just start implementing, and the refinement process comes through implementing different programs and understanding that some things you just need to lay them out. For example, need to understand that there needs to be age appropriate resource creation because the timing that you receive the information is very important as well, because it's not necessarily relevant to you if you're learning, let's say, about menstruation at a really young age, or you're learning about PCOS and so on at a very old age. Meanwhile, you could have experienced it at different times. She also stressed on the collaboration among public health clinicians and communities for better policy creation and support. During our Q&A session, she clarified the differences between PCOS and endometriosis, and there was also discussions on the misinformation that could be received from social media, and there was also discussion on the high cost of period products, the stigma, and how public health can better incorporate cultural knowledge to assist the patients from South Asian communities and so on. We also discussed how there are diagnosis delays and challenges in navigating care, and that there needs to be conversations with the doctor, especially for this population, understanding that you are allowed to kind of advocate for yourself. There needs to be personal agencies. You need to be discussing this to dispel the stigma, but also ask questions, follow up on your test results, and so on and so forth. And the conversation really overall just emphasized how it's important it is to improve menstrual literacy, advocacy, and culturally sensitive and community-led solutions as a whole. Thank you.
Thank you, Amna. Next, we have Rida, who will be summarizing the points from Knowledge is Power, Sexual Health Education, and STI HIV services.
Hi everyone, sorry, my Zoom's giving me some trouble. I'll be able to summarize the session now. I wanted to thank Srutika and Alicia for such an insightful presentation. I hope I can do justice to what was covered. So some of the things that we covered was, first, we kind of went through what ASAP does and the work they do. So ASAP stands for Alliance for South Asian AIDS Prevention, and they're committed to providing culturally responsive, holistic health promotion and support services for people from SAMEAC, so South Asian, Middle Eastern, and Indo-Caribbean, and other related communities who are LGBTQ and or living with in risk of or affected by HIV and other health conditions. So ASAP provides health education services, settlement services, and they also do capacity building projects, such as their Trans Power project, which supports racialized trans and non-binary folks from South Asian backgrounds through sexual health workshops, mentorships, and one-on-one group support sessions. So some of the current and past programming approaches that they have are peer support groups, workshops, large culturally inclusive gatherings, and collaborating with other community partners and curriculum building. So Alicia and Sritika highlighted how cultural expectations, religious norms, migration contexts, and social stigma often limit open conversations about sexual and reproductive health, which contribute to gaps in knowledge and reduce service seeking. Sritika and Alicia also shared culturally sensitive strategies that support South Asian newcomers and women in making informed decisions about their sexual and reproductive health, as well as what worked for their programming at their organization to reduce stigma and increase sexual health literacy. So some of the things that they said that worked for them in their programming was, for instance, providing food, TTC tokens, having language and culturally specific programs, regular peer support workshops, having art-based and skills workshops, as well as advertising sexual health programming and as not being sexual health workshops, and group discussions and swapping stories. And some things that didn't work in their programming was in doing invasive data collection, having dense, inaccessible language, and also not putting in work to build trust, which was something that they highlighted that was very important, is that community organizations need to first build trust before they have these programmings. And yeah, overall, they were able to address the barriers that South Asian newcomer women face and strategies that we can use to support them.
Thank you, Rida, and to all the facilitators for summarizing the discussion. I want to give this opportunity for any of the attendees to ask any questions to the speakers if they weren't able to during the breakout session. Or if the speakers have any last minute comments to add.
I just have one. I think I've spoken a lot, but I think it's important. I've been attending the CASSA's health summits and other summits involving South Asians for maybe 10, 15 years now. My gray hairs tell the story. But I think that, sadly, many of the issues that we spoke about today are issues that we spoke about 15 years ago and 10 years ago, and they keep coming back. So I'm not an idealist to say that these issues are going to kind of, go away in a hurry. But I think that I just want to point out that I'm so happy that the younger people are taking command of the situation and actually running with the issues that we have seen for 10, 20, and 30 years and more. And I just feel that someone voiced it, but meaningful action. So we know that these issues are there. They become more complex as our communities change, whether it's around HIV or mental health, the stigma, the silence, many a times the denial as well. And I feel like let's get some potential action like in collaboration by way of these summit attendees. We're all doing great work in our own organizations, but maybe there is a way that we can collaborate on issues that are really key to our hearts and say that, at one time, I know we spoke about a South Asian, I don't know what it was called, but more like a collective where we actually run with health issues, write grants and things like that. I did mention that faith-based organizations are a great health hub or could be turned into great health hubs. The condition is that you don't have the priests and the imams and the temple priests running that. It's you who actually take ownership of that so that they are run with a non-patriarchal equity lens. But these are great spaces where the community is. So I'll rest there to say if there's any kind of appetite for collaborating on these. I'm there. I'm with the CCMW, and there are many more like me who can be with you all as well. Thank you.
For those, I can see how disheartening it may be to be witnessing so many issues and seeing little progress. But hopefully, we will be the generation to see much bigger improvements, much bigger change. And everyone, please do feel free to connect to Firdaus. She does amazing in her field.
So this is Khadija. I'm just putting my hand up. Firdaus, I'm also with CCMW, and I think that's an amazing thing you brought up regarding collaboration, and maybe we could work together with CASA on reproductive and sexual health, and maybe make a, I don't know, like a presentation toolkit for going into schools, especially schools where women, maybe it's a girls' school, or I don't know if you still have those Muslim schools in some areas of Ontario, and talk about all this, because I think I think in the my opinion is we are only talking about age specific, and the way Dr. Hussain mentioned throughout, starting, from the teenagers to menopause. I think it's good if a person is a girl or a woman knows what the whole journey is going to be like. And then she mentioned something which I really learned new was the genetic predisposition in certain communities and trauma and South Asians. That's really new to me. So I think these are issues that I think we should be focused on. So I know it's 15 years you're talking about, but maybe we need to take that out. And I love your idea of the hub, which is which is not controlled by any one stakeholder, but it's a community gathering. It doesn't have to be just for South Asians, but for women and girls, especially on this topic. So just bringing that up, and we all have our own connections. And if you want to bring in BIPOC community, maybe we can do something like that in a BIPOC community center. Just bringing those up because this is an important subject matter.
So CASSA has recently taken on a project for sexual and reproductive health for South Asian newcomer women. So Khadija, please feel free to reach out. And because we will be starting the project next year. So I'm looking forward to connect.
Sure, I will. Thank you, Madiba.
Do we have any last minute comments? If we have nothing, if no one has anything else to add, I guess we can move on to our closing remarks. I want to thank you all for joining us for our 14th Annual Health Equity Summit. On behalf of CASSA, a heartfelt thank you to all the speakers, facilitators, and participants for your expertise and engagement, which made today's discussion possible. I also like to mention that all the key insights will be captured in our summit's proceeding reports, and the recorded version of the summit will be available on our website and also on YouTube later this year or early next year. Also please don't forget to complete our feedback survey. I will just pop the link in the chat right after I finish. But as always, it's been a pleasure hosting you, and we look forward to seeing you at future CASA events. And we do hope that next year that our Health Equity Summit will be in person again, as it usually is. But I want to thank you all for joining us.